27th annual Lourie lecture. Much of the information I'm about to tell you is in the program, so I will try to be fairly brief, but I think it's important to remind ourselves about this wonderful series that has a long history here at the Maxwell School. It's a lecture that's been held in honor of Herbert Lourie, who is a distinguished physician and a member of the national and international medical communities in the field of neurosurgery. And as you'll see, on the back of the program, there's a list of the many distinguished Lourie lectures that we've had over the years. And it is a wonderful tradition, and it's been an opportunity to bring together our faculty, students, and staff with a very distinguished and thoughtful individual involved in the issues that animated Dr. Lourie's life and allows us to be involved in the current conversations. And we're especially fortunate today to have James Knickman here as the Lourie lecturer, not least of which because his career really epitomizes what Maxwell is all about. A distinguished scholar, distinguished practitioner, a person involved in the interface between engagement in policy issues and analysis. Spent many years as a distinguished academic at our sister, the Wagner School, has his PhD in public policy, so a very well-distinguished academic background, but also played a really extraordinarily important role, a pioneering role in the work of the Robert Wood Johnson Foundation as Vice President for Research and Evaluation. I think anybody involved in the field of healthcare and health policy knows of the really remarkable and seminal role that RWJ played in this field. It's hard to think of an instance, in my knowledge, where a foundation has played such an important role in contributing to the depth of the knowledge that we have about this critical policy issue and in ways that have had enormous impact on policy itself. I think you can trace enormous amounts of the evolution of healthcare policy at the local, state, national, and even international level to the work and the research funded by RWJ, and Dr. Knickman obviously played a critical role in making that happen. And in yet another iteration, which is also very dear to our lives here, he is the first president and CEO of the New York State Health Foundation, which is a really innovative foundation dedicated to improving the health of all New Yorkers, especially the most vulnerable. And it's an issue that we have a great deal of interest here. The Lerner Center has been very focused on those issues. I know Tom is here somewhere. I saw him. There he is. And so it really goes to the heart of what we're all about as well. This is something that is really quite central to us, and I think the turnout of the audience here really reflects how much interest we all have that here. His topic today is patients as consumers. Is it time to make healthcare like other service industries? This is an issue that as I told Dr. Knickman, I've myself had a little past involvement with for several years as minority counsel on the Labor and Human Resources Committee in the early 1980s, working for Senator Kennedy, and the whole question about how and in what ways can we use the instincts and the impulses of consumers, but also to recognize the distinctive features of the healthcare system, which are somewhat different than buying cereal. So we'll have a chance to hear his reflections on this, and then a chance for you to ask questions and become involved in the discussion after the formal part of the lecture is concluded. So let me ask you to welcome Dr. James Knickman.
Really pleased to be here with you today, and really honored to be asked to give this lecture. And it is a very impressive list of predecessors. And I guess the good news is I know almost all of them, and I've funded almost all of them. So I know that, and because of that, I know I probably can't match them in many ways, but I'm really pleased to do it. And I want to note one person on this list in particular, who's Jim Talon, who is a distinguished alumnus of the Maxwell School, went on to be the assembly leader in New York, very transformed the Medicaid program in the state, responsible for a lot of that legislation, and now heads the United Hospital Fund, which is, again, a good sister organization of ours in New York. So I just want to recognize Jim, and he's always telling me what to do and think, so it's good to do that. But also note, some of my ties to this school. John Palmer was on my board of directors for a number of years, so he was my boss, and he was a great boss, always thoughtful and quietly influential, and so that was great. And Doug and I, Doug Wolf, shared an office as graduate students. We sort of shared an office. We had a wall between us, sort of, but when we were at the University of Pennsylvania, so we go way back and still haven't solved all the problems that we were trying to solve, I think, even then. So it's sort of very nice. And I want to note, our foundation, every foundation executive starts by talking about the nice things they've done for whoever they're visiting, and Syracuse has been a great grantee of ours in a number of projects. And currently we work with the folks who do veterans reintegration. Jim McDonough has been a grantee, who's a visiting fellow with us for a long time. They do great work on sort of helping veterans returning from Afghanistan and Iraq resettle and get back into everyday life. And we've been a supporter of their work, and it's one topic that we're very interested in as a foundation. And we funded some work. I think you were involved, Tom, on regional variations and trying to understand how variations in costs and utilization and stuff using Wenberg-esque type data, another one of your speakers. And that was really important. And the whole group of you, I think, are really actively engaged in our Healthy Communities initiative, which is really trying to improve population health at the neighborhood level, working with folks at the near west side. That was, I always want to say the far east side, but it's the near west side. And that's a really interesting program, great hopes. I've visited it a number of times, and it's sort of, you feel the sense of community and stuff that's going on, and so that's really great. But anyway, it's really nice to be here. I do, when I think about my career, I always feel, especially when I'm at a university, I admit that I feel like I'm sliding down the intellectual, slide. I started out as what I thought of as a serious researcher at NYU, and did research with lots of fancy regression equations and lots of theories and stuff. And then I went off to the Robert Johnson Foundation, and I funded research. So that was actually the most fun job, because you get to design research, but then you don't have to do all the hard work, and then at the end you get to help interpret what it all means and how to use it. But anyway, that was a great privilege to do that. But I still felt like I was academic-ish, when I was funding research and judging people's proposals and stuff. But now at the New York State Health Foundation, we're much more applied. We're much more really trying to improve health in this state, and we want to make a difference. We want to have impact. So I've decided that I now am a user of research, where we sort of try and take ideas that have been shown to work and try and spread them around the state and make a difference and stuff. And we try to, change the system so it's a little more responsive to what people need. So I've sort of gone from doing it to funding it to using it. I don't know where you end up in that slide, but anyway. So I'm really pleased to be here. And let me, this is a little edgy, at least it's an edgy title. I don't know if it's an edgy talk, but it's an edgy title of sort of trying to get your attention on this. But this talk is really about a simple point of importance, at least to me. It's something that I sort of been thinking a lot about over the last few years and really care about. And I really will just try to make the case that there are two crucially important challenges facing the American health system right now. And these are the things I think we ought to have front and center as we think about how to improve health and healthcare in this country. The first is, I think I have a slide I should move here. The first is really creating an effective model of care that is affordable for the working and middle class. And argue that I do not think we have that right now. And the second is to start to treat patients like they are the center of the medical care experience. And I do not think we've been doing a good job of saying the patient is the center of the medical experience. And before I get into it, I just wanted to preview these ideas with one of my slides and one story that sort of gets at why I care about this so much. And this slide this is interesting. I did this slide myself. That's why it doesn't look so pretty. My staff didn't do this. But and I want to look at it with you. But what this slide does is say, what is the burden of health care for American families? What is this costing us? And so actually I found the tax calculator thing on the web that says what the taxes are. And luckily for me, they gave 2 examples of how it worked. And it was the examples I really wanted: $50,000, sort of a middle class, a median income-ish type of salary, a little bit below the median income, I think. And then I looked at somebody makes a family that makes $150,000. And if you look at what happens to their money, it goes something like this. The $50,000 person, the average employer family premium right now is $12,500. So if you think about that as part of their compensation, which we economists like to think of as compensation, then it's $62,500 is their total compensation. They pay, according to the tax calculator program that I found, at least this, and this is for California because that's what they gave me, they pay $7,500 on average in taxes, and so their after-tax compensation is $55,000. Look what happens here to their expenditure patterns. You think about, first of all, $12,500 is the employer premium. That's gone. And then they on average, a family pays $5,000 in premiums for health care insurance. That's gone. The average deductible is approaching $2,500 in insurance, and it's not quite there now. It's going to be there in a year or two as we get to the Cadillac tax, which I'll talk about later. And then they pay $725 in Medicare tax. And I thought, well, that's really an expenditure because they're sort of saving money through the tax system for their future health care. So they fully spend $20,000 of their $55,000 compensation, their after-tax compensation on health care, and that's 38% of their total money. That's unbelievable. And just $33,000 or something is left, or $34,000 is left for everything else. That's $3,000 a month. That is a big burden. That is a real affordability problem in my mind. And by the way, I sort of assumed here that they only spend money up to their deductible. If they spent more money, they're probably paying copays and out-of-pocket things that aren't covered, so it might be even worse. And I should also note that in this example, the person doesn't necessarily touch their insurance. And we're getting to the point where I'd say traditionally about 50% of people never touch their insurance because they either were healthy or they were below their deductible and their total expenses. That's going up every year as deductibles go up and more things are excluded. And so this is a person who's paying 38% of their compensation to health care and not really seeing a dime come back to them. That's a big burden. Now, if you go through the same numbers for the $150,000 person, it's not quite as bad because that person pays pretty much the same employer premium is going out, the same employee premium, same deductible. The only thing difference is they're paying more for Medicare tax. And if you look at it, it's $22,000 instead of $21,000. And it's 19% of their income. So this affordability issue really is hitting the middle class, the working class in this country, and I think it's really, I'll come back to this again, that this is really central to the whole equity issue in this country of who's getting the money, what are the disparities in income, and I think that health care costs are a big driver of that. And I think that has to change. We just have to figure out something to do about this affordability. Okay, so the story I wanted to tell is about I was at a meeting. I don't have a slide on this, but I was at a meeting and this healthcare executive. This was downstate. This was down in New York. Was giving their annual talk about how the healthcare system, was treating hospitals. And this person went on and said, they went on, I'm losing my place here, they're talking about all the stakeholders that hurt them and are hostile to them. And they were talking about the importance of insurers, the importance of employers, the importance of government, the importance of physicians who are people trying to steal their business, the importance of the problem with innovators like retail clinics that were taking business away from them. They were evil. The pharma industry was evil. The device industry was evil. Went on for 30 minutes like this. Not once was the word patient or consumer or individual mentioned. Never mentioned. It was like patients don't exist. It's pharma that exists. It's insurance companies that exist. It's government that exists. And the hospitals are more, that's what they're thinking about when they're thinking about their market and their industry. And that's just a real problem. It's just sort of, I think it's, it just causes lots of concerns if that's not it. So the question that this all leads me to is, well, okay, how do we address the affordability issue, and how do we get the health system to be more aligned with the needs and wants and sort of the person they're treating it? I will note that every other industry in America, virtually every other industry in America, spends an awful lot of time worrying about both the affordability of its products and what the consumer wants. I mean, there are some examples like Apple and Uber that somebody comes up with this brilliant idea of what they think they can convince Americans they want, even though they haven't had it in the past. But for the most part, companies go out and they study consumer preferences, they talk to people, they find out how they can please customers, and they build their whole business around that. Not in healthcare. It just doesn't work that way. They worry about what the government payers are thinking and what the insurers are thinking and so on. So it just seems like everything's turned around in terms of importance here. Okay, so that's what motivates my concern and sort of is leading me to think about what we do about it. I'm going to take off my jacket. Oh, I can't take off my jacket. Oh, heck with it. I'm all wired up. Sorry about that. I should have done that earlier. So let me get started. So, and what do I want to accomplish here? But before I say that, I'm going to sort of take my academic card out of my pocket. You're allowed to do this in academia, especially when there are economists in the room. And I'm going to take out my I'm going to assume card, sort of you can assume things away. And the thing I'm going to assume away here, which you won't like, some of you, is that I'm going to assume that we will never in my lifetime have a single-payer universal healthcare system, which might solve the problem. But I don't think that's in the cards, given the politics and given where we're at right now. And so it leads. If I take that off the table and say that's not going to be a solution I look at, it leads me to think in terms of market forces as the possible path to affordability and to patient-centeredness, the efforts to get that. And I must say that virtually every market in America has focused on this challenge. As I say, I mean, they focused on it in one way or the other. Now, I think that, by assuming away the possibility of a single-payer option, I really simplify my time, it really simplifies my argument a little bit. I really can take something that's very possible off the table. But I do think it's actually a complicated debate about whether if we had a single-payer system, which has lots of equity attributes, if we had it, would it really increase affordability? Would it really increase patient-centeredness or not? And I think you could argue that back and forth, but I'll let others do that. And I would recommend, I have a citation here too, but a 2010 Health Affairs article that really lays out some of these issues pretty conceptually, and it's worth doing. But I also will note that even if I'm saying that I think a single-payer system isn't going to happen, whether you like it or not, I do think there's lots of roles for public policy. I don't think we're going to, we'll see. But I mean, one approach is to create a market that works perfectly. Good luck with that. And the other possibility is to fix a market as well as you can, but use public policy in terms of shaping things in a good way and maybe regulating things so that they get to better outcomes. So it's not where you're taking public policy off the table or government roles off the table, but just sort of this idea of a single-payer system. Okay, so that's what I want to do. So here's the outline of what I'm hoping to accomplish. and this is, I really want to address why is affordability a concern? Why is affordability emerging as a key issue right now? Why do I think it's front and center? In what ways is the health system not consumer-friendly and patient-centered? And why is this a problem? Why, who cares? I mean, is it important or not? So those are the key issues or the problems I want to deal with. And then the possible solutions that I want to go through are what can we do to make the system more consumer-centered? What sort of obviously I want to talk about solutions. What can we do to address affordability? What are some of the options out there? And then I want to turn to New York, which I know the most about, and really talk about what New York State, and to some extent the federal government, is doing to address these issues successfully. So I want to take you through what we're doing, I think, as a state to address these issues. And I'll end with a grading our performance on addressing these issues in different dimensions. So we'll look at that. And then I'll try to get to how can a philanthropy like ours be helpful? Is there a role for philanthropy to try and make the system more consumer-centered and more affordable? And I hope there is, because about a month ago, our board and our staff agreed that we're sort of making one of our priority areas to improve consumer-centeredness of the health system. So it's sort of something we're going to do, and we are really working on exactly what the strategies are. So it's not like this was a random topic I came up with. It's something not only are we thinking about, but we do want to spend money to try and make happen. So we'll get there. I think as I start, I'm not sure I'll convince all of you to think the same way I do about this. So I have a feeling there'll be a good, vibrant discussion at the end, and that's great. Okay, let me start on affordability as the first thing that I talk about. And I'll just give you some numbers. I think that first slide, to me, is the most convincing number. But here's what's been going on. So from 1999 to 2015, we've seen a relentless increase in premiums. Premiums paid both by employers and premiums paid by out-of-pocket. The dark blue is, or is that purple, is what employees pay, and the light blue are what employers pay. It basically comes out to about a 7% increase per year, and maybe this is useful. Interestingly, the amount of money that employers have been spending has been increasing almost at the same rate as the amount of money that employees have been having to pay for premiums. So, we always think that more and more is being pushed to the consumer, but it's been pretty proportionate. And I guess in the last 5 years, or actually, it's 15, it's the last 5 years, we've seen a little bit of an uptick in the blue line, the workers' contribution, but they're going up pretty parallel. And of course, the problem is that they're going up much, much faster than wages are going up, and of course, much faster than inflation is going up, right? So it's sort of, and that's where it's, that 38% of compensation that's being used to pay for healthcare used to be 20%, but it's just been being a bigger and bigger percent of compensation over time. And again, this is all part of the issue of stagnation of wages. Is if people's wages were going up 7, 8, 9%, you might not be so concerned about that increase in healthcare costs. But this is really hurting purchasing power for other things. Okay, another, let's see, just for the record, because this comes out to be part of the story later on, is deductibles are growing very quickly also. There was a Kaiser Family Foundation survey that just came out that they've gone up 50% in the last 2 or 3 years. They've been just sort of increasing quickly. Deductibles that people have to pay. Remember, a deductible is how much you pay before your insurance kicks in. Right? You have a $1,000 deductible, you have to pay the first $1,000, and then your insurance starts paying whatever they pay. Okay, and then this one sort of gets us back to the first slide. This shows how the average health insurance premiums as a percent of median income. It was slightly more than what we had on the slide, but you can see how that's grown from 15% to 23%, and then this is where the slide was supposed to be, but I decided to pull it up and talk about it at the beginning. So this is where we are. Okay, so that's the problem with with affordability, and I think the problem is even exacerbated when you say, well, what do we get out of that money? What are we getting? Great things because of it? And in truth, we're not getting great things because we spend more than almost any other country. I think we spend more than any other country. And yet we're 38th in terms of life expectancy. There's little relationship between spending and outcomes. This is a table I think you guys did for us, actually, which is looking at the green is sort of communities ranked by quality indicators. You can correct me, Tom, if I'm saying this wrong. By quality indicators, the ones on the left are the highest quality outcomes using Medicare data. The ones on the right are lowest quality. And the blue line is just how much they spend relative to their peers. And I don't think you have to be a Doug Wolf-style regression analyst or statisticians to realize that that's a pretty random-looking blue line flat across there, saying there's not much relationship between spending and outcomes, at least in New York at the community level. There's probably ecological issues, but that's all right. So that's a concern. Now, let me come back to this slide here. So little relationship between spending and outcomes. Unaffordable care leads to patients delaying and foregoing care, amazingly, because they just have no extra money to pay for any other copays. And unbridled growth in healthcare spending is leaving fewer resources for other things. And I think we've been reading more and more about this. And if you look here, this is state and local spending, and the blue is the blue is spending on non-health care. That's going to go down over the next few years from 10.4% to 7.7% of the budget, or of GDP. And spending on health care at the state and local level is going up from 4.1 to 7.2. So if you're interested in schools, and you're interested in social services, and you're interested in highways, there's less and less money for any of those things because of the money being driven out of the system by health care. And that's a concern. And it's really a concern. What's her name up at Yale? Betsy, I forget her last name now, but there's more and more research showing that Europe is probably doing better on health outcomes because they spend more on social services and less on health care. We spend a lot more on health care, not much on social services, and get a worse outcome. And there's just sort of more and more evidence saying that might not just be correlational, but it might really be a factor. So if we have less money to spend on social services because it all goes to health care, that might not be improving well-being. So we're not getting a great deal out of all this. But I will say, having said that, is I don't want to say, be too dire. Healthcare is really helpful. It's sort of, I'm not saying that healthcare has no impact. It is helpful, and there's a lot of evidence that access to medical care is important. When people get coverage, their outcomes improve and their access improves. There was this great study done in Oregon, I guess it was, where not everybody could get Medicaid expansion, so there was sort of like a natural experiment, and you could see the people who did get randomly picked to get Medicaid expansion had better health outcomes pretty quickly than the people who didn't get Medicaid coverage. After 65, there's a whole series of studies, some folks out at Berkeley and other places, showing that disparities in outcomes in healthcare across races decrease because of, and the presumption is because all of a sudden everybody or most people are eligible for Medicare, whereas the difference in coverage among races is starkly not equal before people are eligible for Medicare. And the other thing, we are seeing advances in life expectancy. Unfortunately, so is Europe, and they spend a lot less than us. But it's not like we're not seeing things get better. And of course, there are lots of promising breakthroughs that we will want to spend money on. All this genomics, all these personalized drugs. There's a whole bunch of things that are not going to be cheap that probably will have an impact on our health. So I don't want to sort of write off all of medical care and say it's a waste. I think it's actually good. My problem is that it should be affordable, and that's what I want to push for. Okay, why is affordability concerned right now? Why wasn't I concerned about this 20 years ago? I think I was concerned about it 20 years ago, but I think it is really important right now. First of all, there's really tight government resources. You might have read that a lot of people in America don't want taxes to go up, and that's what will have to happen if we're going to spend more and more in health care. And also, there's a rising share of the cost is being borne by people. So the Affordable Care Act there's unbelievably high deductibles in those policies. You know, people are buying $3,000 deductibles, even $5,000 deductibles. So more and more people are going to feel the burden of the cost of health care as we have these less generous health insurance policies. And it's going to get even worse, not only for the poor, but also for everybody, if there's not everybody, but most people, if they put this Cadillac tax in, which is a 42% tax on employers' support for health premiums. I think it's above $10,200 for an individual and $15,000 or something for a family. I forget exactly what the rates are. But more and more people are going to be having their employer pay more than the minimum for this tax, a 42% tax on your payments of premiums. And clearly what employers are going to do to some extent is reduce the quality of insurance coverage to get it back down below the tax amount, and which will probably lead to even higher deductibles, even for faculty at Syracuse University. You know, so it's sort of that's going to make this even more. The potential explosion of expensive new drugs and treatments leads to concern about affordability and how it's going to affect people. And again, the stagnation of median income. If incomes were going up at 7-8% a year, we probably wouldn't be as worried about this, but they're not. So, okay, so those are why we are worried about it. Now let me turn to the consumer-friendly side and the patient-centered side. Why is the health system not consumer-friendly? How did this happen? And what do we do about it? And I think that why it happened, I think is really what I started off with. I'll just say a little bit more. Is the individual historically hasn't really paid for health care when they need it. They pay for it up front through insurance. That's what's happened typically. And so it's the insurance companies that are the ones who are doling out the money to hospitals and physicians. So that's who they pay attention to. It's just sort of natural. We've taken the price signal away from the consumer, given it to the insurance company, so the consumer is no longer the one to please. And that's true for government payers and regulators also. The regulators and government payers almost have more influence on the financial health of a hospital or a physician practice than what an individual does. And then finally, there's just really poor market forces that make which ends up making competition in consumer shopping a rare event. Sort of the way the system is designed is very hard for competition to occur. It's just patients go to doctors it's such a complicated product, healthcare, that it's not the same as comparing one TV to another TV. It's just more complicated, so you tend not to shop around the same way. And of course, the fact that you're not paying for it out of pocket makes you not shop around for it in the same way. So that's how we got here. I think it's just sort of a market that's it's not really a market is our problem, I guess. Okay, so why is this a problem for consumers? Well, I think that the issue here is that increasingly I find that consumers feel lost and abused. And it's interesting, I can start with my board members and people on my staff, and you probably hear it too. There's just so many stories of when somebody has a health problem, the saga they go through to get the services they need. And that's sort of, I think, the cumulative effect of that is just really upsetting. I had a friend call yesterday who had back pain and he had to have surgery, and he wasn't sure whether he should do this surgery or that surgery. And it was so demoralizing to him and he went to 4 different doctors. 2 said to do this, 2 said to do that. Very unclear how he could get the advice he needed to make a decision. And I said, well, you could go to a 5th, at least have an odd number. But but that's sort of scary, And there isn't a good consumer assistance bureau to help you say this is how you go through all that. So I think there's more and more of consumers feeling that they don't quite understand it. And I think part of it is that it's complex products. What we consume in healthcare is complicated. Information is really opaque. And And there's not enough co-management. I think a lot of patients don't feel they're being asked to be part of getting them healthy. You know, I have a brother who has diabetes, and he's not very attentive to himself in general. But I come home, I said, well, what did the doctor say to do? And he said, he didn't tell me to do anything. He said to come back in 3 months. And I don't know, I assume the doctor must have said something to him. He should be doing a lot of things. But it's interesting how there's at the very least, there's no communication between the doctor and the patient. My brother didn't walk out with marching orders, and maybe he didn't get marching orders. I don't know, but I told him I'd go to his doctor with him next time and get his marching orders. But so I think that the co-management is important. The fact that it's hard to get information is important, and it's a complex product. And then, again, I think consumers are upset that there's a lack of affordable choices, and now they're facing high financial responsibilities with poor information. Okay, so I think that's the problem. That's the setup for the problem. And now what I want to do is go to the second half and really say, are there things we can do about this? Are there things to make this better? So this is what we want to do, and these are the tough questions. This is where the swamp starts, really trying to do something about it. But we want to look at what can we do to make the system more consumer-centered, what can we do to address affordability, and what's the state doing to do it, and what could a foundation like ours do to help out. So that's what we're hoping to get to. Okay, so when I first started thinking about this, and our staff started thinking about this, and we said, okay, we'd like to think about improving the consumer experience. You know, we went away on retreat a day long to say, okay, what can we do? And of course, what do you do when you say, first of all, we couldn't decide what to call it. Is it consumer empowerment? Is it consumer centeredness? Is it consumer engagement? What do you, it sort of was very, but anyway, so of course, you do what everybody does these days. My senior vice president started Googling all these terms, you know. Well, what does Google say consumer centeredness is or consumer empowerment is? And interestingly, these are the three types of buckets that came up. You know, it's sort of like some people would talk about customer satisfaction. A consumer-centered industry is one that would be trying to give people customer satisfaction. And amazingly, you know, you quickly get to amenities. You know, things like better access to your lab results. Right now, it's very hard to get lab results. It's hard to get any information about your health status or what's being done to you. People would like customer-friendly office hours. People would like to make it easier to have to be able to make appointments, right? They sort of I don't know. I always have to make 3 or 4 calls. It seems like to make an appointment. All those types of things. They'd like more friendly visiting hours. It's sort of when you look at the list of what people think of as consumer-centered, a lot of these things are most of us in the health sector would consider them trivial. But they're not trivial to the consumer. You know, they might not be what I want to spend my career doing, which is designing a better hospital gown, but that's important to some consumers, and we don't do it. Any other industry would attend to it. And why don't we get better hospital gowns? Would it be that much, is it really that difficult a problem to get a better hospital gown? What? No, why should we? They're going to come to the hospital anyway. So, but anyway, so that's what we got at the first Google. The second Google was, there were all these health service research nerds clearly Googling this. There were all the patient-centered model stuff, right? Sort of care management, medical homes, care coordination, focus on quality, all of those things. But that makes sense. That's a part of consumer-centeredness, is sort of having models of care that really coordinate services. And again, we'll come back to that is seen as a big issue now. And then finally, there was a lot of stuff we would see on transparency and affordability. When you say, you know, improve the consumer experience, you'd get things about the fact that we don't know what prices are, we don't know what quality is, we don't think payments tied to value, all these types of things come up. And think about it, this is an amazing industry, right? With the new ICD-10 codes, there are 70,000 codes. That means, theoretically, there are 70,000 prices that hospitals and physicians charge for different things they do. I mean, can you imagine if there were 70,000 prices to buy a Honda? I mean, now there are a lot of prices to buy a Honda. You can get one without navigation, with navigation, there are different things. But it's a lot simpler than 70,000 prices. And in fact, if you go to, if you go to most hospitals and you say, gee, I have to have a knee replacement, how much is it going to cost? You know what they say? It depends. And can you imagine if JetBlue this morning, if I went up to them and I hadn't paid for my ticket and I said, I want to go to Syracuse, how much is it going to cost? And they said, it depends. I'd say, you're crazy, give me the price, And in fact, of course, I can look at that price on Expedia or any website and get it very quickly, but we don't do that in healthcare. It's very hard to get prices. It's very, I talk to my friends who are physicians and I say, well, how do you decide what to charge? They say, I don't know. Sort of like there's I don't know. It just happens. So it's not not out there. So that's the type of thing about probably one of the most important things is a lack of information about prices and and the same lack of information about quality. We just don't. People don't really understand all that. Okay, so we'll come back to some of this again. So then I decided that we needed a logic chain, right? We sort of need a logic model or logic chain to say, well, what are we thinking about here? And our logic chain was that if you improve transparency, and if you improve competition, and if you had more innovation, and if you had better financial incentives both for patients and consumers, patients and providers, that you would then get to a world where providers would focus on the patient experience more. They would try to lower costs and they would offer more choices. So this is what we're hoping. And then if that happened, we'd get to better cost structures, better quality outcomes, and more customer satisfaction, and maybe even better population health if you really created the right financial incentives. So that was sort of what we were thinking we wanted to accomplish and how we at least set it up. Then after a little bit of more effort, we said, okay, well, we know these 4 buckets at the bottom, what we would like to see happen: more affordable choices, more transparency, higher quality care, better patient outcomes, and a better customer experience. And we realized that one way of looking at it is to focus on the macro drivers, to be good economists and say, what we really need to do is rebuild the market. And if you did that, I think you'd have to work on these 4 things. You'd have to somehow get competition to be working, right? So to get hospitals to compete. In New York, we have 4 or 5 medical centers. I don't know if they really compete too much. They sort of seem to do well without competing, and they're all in the same. They're all, everybody can go to any one of them. So it's sort of it. But we have to figure out how to push competition. We have to rethink payment approaches. Right now, our payment approaches have no incentives for efficiency, no incentives for value. They're just not very good. And that's true of the payment approaches for individuals. If you don't have to pay part of the cost, you're probably not going to worry about it. And you're not going to shop around as much. And then, very importantly, we need understandable products. And I think this is one of the biggest hurdles is you can't have a hospital say they do 70,000 things, and you have to say, we do hip replacements, and we do knee replacements, and we take care of people with chronic diabetes. And maybe we take care of people with chronic diabetes that is very severe, moderately severe, and not severe at all. Maybe those are 3 different prices. That's like the Honda with navigation and Honda without navigation. It's slightly different. You charge a slightly different price. But you have to be able to define what are the products that you're selling if you want to have any market forces at all. We have not demanded that in healthcare. It's very hard to get a price. If you look on the Hospital Association of New York State's website, Haney's website, they have a guide to figuring out medical prices. I can't believe they did this. And it's this really nice report. And it's very accurate. And it actually tells you, they say, if you think you're going to have to go to the hospital or you think you have a major medical thing, go to your doctor and ask him every ICD-10 code that he might use. and ask him what his price is for every one of those ICD-10 codes and what are the probability he will use it. And then you can put that together and get a likely price that you will pay. I thought, man, you do need a PhD in economics to figure this out, you know? And then, this is a really great one. He said, the report says, and once you do that, go to 2 or 3 other doctors or hospitals and ask them for the same information. You show me who's going to sit down with you. I mean, they'll probably charge you $300 to go through this exercise. But anyway, so that's their advice on how to get prices. That dog definitely doesn't hunt. You know, you can't do that. And so we have to figure out how to do it. So you could say that's what we need to do. We need to take care. Oh, and then there's disruptive innovation. I didn't say it, but what do you learn in your first week of economics is you have, for a market to work, there has to be the ability for people to enter the market who are innovative, and there has to be a way of people exiting the market who are inefficient and not good. There, you know, have to be entry and exit. And in healthcare, there's been a real problem with entry. You know, it's very hard to say, I don't like the hospitals in Syracuse. I'm going to build a new one to compete with the ones that are here. Just a very sticky approach. First of all, you wouldn't get through the certificate of need process and everything else. But even if you did, it would be very hard. And so there has not been, and there hasn't been as much encouragement of that. We are seeing that change, of course, right? All of a sudden, we have these disruptive innovators. Thank God for the millennial generation. They like startups. But we are seeing things like ZocDocs, you know, which is a online appointment tool that's just like OpenTable, where you can make restaurant reservations. And we're seeing a new insurance company, Oscar, that is really focusing on telephone calls and web, using the web to get quick answers to certain health problems from doctors and stuff. So we're starting to, but we need that disruptive innovation if we want to see the market change much. Okay, and then maybe those things would lead to these things at the bottom that we really care about. I think that I'm going to go through each of them, but I think that you probably also need some public policy to push a lot of these things that you want at the same time. Okay, so let me go through each of the ones on the bottom, which are in some ways what we thought, as we were developing our thinking about this, the top part we thought of as the macro drivers, and then the bottom are the sort of more micro things you could do. And interestingly, just to skip ahead as a foundation, the way we think is, okay, which of these 8 things should we work on? You know, we could pick one of the ones on the bottom and say, let's just try to improve transparency and you know, pick a piece of it, or let's try and improve the customer experience or satisfaction. Or we could say, we want to spend all our attention trying to get more competitiveness in the market. You know, so, and I think that's true of public policy too. They have to say, where do they want to intervene? What's the best way of trying to straighten this out? And of course, you should always ask your question of, do you have to straighten them all out to get progress, or could you straighten 1 or 2 out? Because sometimes you straighten 1 or 2 out, but unless you do all of them, it's not going to lead to change. But okay, so let's go through these. Addressing affordability. So this is interesting. This goes back. Here's just a couple of things that I think. First of all, most of what we're doing to address affordability as health service researchers and as government is trying to reduce costs by 1% or 2%. You know, if care management works as well as it possibly can, it would probably save 1% of costs. And I would argue that we don't need a 1% savings or a 2% savings. We need 20% savings. When you go back to that first slide, and it's 40% of your spend is on healthcare, we need disruptive change. We need a big change in that to make it affordable, or at least an option that is affordable. I'd be happy if there was one option that was 20% cheaper on the menu of possibilities. So you know, you have to think big here and not go for the 1%. I guess if you had 21% solutions and could you put them together, that would get us to 20%, but not sure that we're going to get to that. So I think a couple of things that should be on the table to increase affordability is disruptive innovation. Again, we should be encouraging people to come in with more and more ideas that would go after costs. I think, you know, One example is retail clinics that are really trying to take a part of the market and say, we're going to do this more efficiently. We're going to use emergency room docs who know how to do things quickly, and we're going to have long hours and be open and limit what we do, and probably a lot cheaper than emergency rooms and so on. So you want to encourage that type of thing. I think you have retail clinics all over Syracuse, just like we do over Manhattan. I can't walk 4 blocks anymore without running into a retail clinic. So that's an example of where there is possibilities. I mean, somebody should be funding a whole bunch of startups, your incubators, to come up with more and more, I think, of these disruptive types of innovation. And remember, what you really hope that disruptive innovation does is get the big players to wake up, you know, and start to innovate themselves, you know, and that you hope happens. It's sort of, it's like, again, we were talking about Uber at lunch a little bit, but, you know, the amazing thing, I always say, the amazing thing about Uber that bothers me is that the New York City Taxi Commission should have thought of the idea. I mean, where were they? That they didn't think you could have an app that would get taxis to where they needed to be? Well, they didn't care. They didn't have any pressure. But in the end, I bet you every city ends up replicating Uber in one form or another within the established taxis. Or maybe it's too late. Uber's a huge force at this point. But and maybe hospitals will, or emergency rooms will figure out how to have their own retail clinics. But again, the disruptive innovators, sometimes the role they play is to wake up the establishment. I think we could have, this is where it gets dicey here. Well, I'll start with the least controversial one in my mind is the middle one. One of my personal vendettas or campaigns, not a vendetta, one of my personal campaigns is to try and get large medical centers in New York, especially ones that have a lot of salaried physicians, to start up Kaiser type of HMOs within their system. Okay, so you take Montefiore Medical Center in the Bronx. It owns its own insurance company, so that capitates them right there. They have about 2,000 salaried doctors, right? And so I've been saying to Steve Saffier, the CEO, why don't you take 200 of those doctors and call them an HMO and call them Kaiser East, and in a sense put up a fence around those 200 doctors and say, we're going to act like Kaiser acts, and we're going to deliver care more efficiently. We're going to make sure you don't get tests you don't need. We're going to make sure you don't get double tests. We're going to keep you out of the hospital as much as possible. We're going to let you call us on the phone, and we're going to answer things by email. But sort of with it, so you're giving people choice. They can go to any of the 1,800 doctors and pay more, or they could go to this gated community of 200 doctors that are going to agree to really try and be more efficient. I think that's doable, and I think there are a lot of large facilities that could say, what we're going to do is offer something that's more restricted, be unapologetic about it, say you're not going to be able to go to every doctor in the world, this is it. You already can't do that anyway. But so that would be an idea. Another interesting low-cost alternative is there are companies that are coming up and saying, we will manage primary care only. And so we'll take a capitated amount to take care of all of your primary care. So there's this company they're out of California, but they're coming east, called Iora Health, that basically does this. This is their sales pitch. I think it's interesting, is your typical spend in America on primary care is 5% of total insurance revenue, right? It's sort of 95% is for hospitals, specialists, tests, pharma, all that stuff. 5% is for primary care. It's amazingly small. So what this company comes in is they'll go to Excelis or some company and say, you give us a population of patients, ones that are willing to do this, and we will deliver all their primary care, but not for 5%, but for 8%. We want 8% of your revenues. But we will guarantee you that you'll save more than 3% on your back end. We are going to do such good primary care that your ER use is going to go down and your hospitalizations are going to go down and your use of tests are going to go down and stuff, because we're going to do good primary care, advanced primary care in a typical way. And you know what the two things they do that is the biggest way they reduce their costs, the overall cost, is they make sure there's a psychiatrist at the primary care practice whenever it's open, and then make sure there's an orthopedist at the primary care practice. Because so many people get sent to orthopedists because they have a back pain. If you had an orthopedist at the primary care office, they could come in, do a consult quickly, and decide whether this is a wait and see, or whether this is, you need a whole bunch of MRIs and so on and so forth. And they save a lot of money on that. And with the psychiatry one, it's that there are so many people come in who are depressed, and the primary care doctor is pretty sure that they should be on this medicine or they should have this treatment course, but they would feel much more comfortable moving on that if there was a psychiatrist who he could just either call on a phone or have them come in, and or have them, just sort of in a sense, do a quality check to make sure that was the right thing. And those two things alone apparently save an awful lot of money. Once you send somebody to see a psychiatrist, once you send somebody to see an orthopedist, they're in a new orbit. They're in an orbit of expenditures, and it happens. So, that's a disruptive idea. That's an interesting one that one could push. You could do the same thing. I'm not sure how this would work because I don't know much about it, but you could really offer an amenity-free system. You could offer a system that is very low on amenities, and that might save money. So if you go to the hospital, you go to a hospital room with 4 people in the room. You don't get a private room, or if you're going. I don't know what they would be, but you could think of things that might save money on amenities, and maybe that wouldn't be so bad. People buy stripped-down cars all the time because they want to save money, and it's nice that you have an option to buy a stripped-down car, and that you don't have to buy the fully equipped car, and the same thing. It's nice that you don't have to buy a BMW. You can buy a Kia that's more affordable. We have not figured out how to build a Kia for healthcare. We have not figured out how we can have something that's affordable but not fancy. And I think, Americans buy Kias, Americans buy Vizio TVs, even though they're cheaper and probably not as good. Americans bought the cheapest exchange policies consistently that were on the market, with high deductibles and all. Americans buy the cheapest paper towels they can find. It's why don't we wake up and say that people care about affordability? This is something you need to do. And then there's easier ones, things like reference pricing, which is reference pricing is where an insurer looks across a community and sees that MRIs can vary in price from $700 to $7,000. And they say, okay, $1,100 is what I'm going to pay. Here's 5 really high quality places that'll do an MRI for $1,100. If you want to go to another one, go right ahead. We're paying $1,100. You pay the rest. So you can begin to say, put limits on things like that. And then this is a really tough one, would never happen in New York, which I call take your chances coverage elements. This is what the people at the Manhattan Institute and a lot of conservatives want to do, which is say, let people buy rotten policies. Let them buy policies that only cover primary care and doesn't cover hospital care, or buy policies that only cover, the last 10 days of hospital or whatever. And what we've done in the healthcare system is pretty much, surely in a state like New York, weed out those policies that we think of as not offering adequate coverage. Maybe we're being too protective. Maybe if Americans want policies that don't only cover primary care, we should let them do it. And I can tell you that this is popular in Nebraska and Iowa and Idaho. People don't like to be told what to do. So in some ways, I think all these choices are driven by professional thinking as opposed to what the market wants. I'm not sure I'm really in favor, but I thought it was only fair to put it on the table since Manhattan Institute is one of my grantees. Okay, so that's some of the affordability ideas. Again, I think what we need is I almost think as a society we should say, we're going to appoint 10 people to figure out options that are 20% cheaper that are not horrible, and that we should commit ourselves to doing that. Maybe we could do it in New York. Transparency. This seems so obvious. We need clear pricing for services. People deserve to be able to know what they're going to pay, and what their share is. I think we need to force the health system to think about products and to say, okay, I think we should say to every doctor, you can only have 30 prices.
You pick them, but you can only have 30 prices. And hospitals should have a limited number of prices. I'm going to tell you a little bit. We're going to do a project with Fair Health, an organization that also has some ties to Syracuse, where they're going to develop prices for 200 most commonly used things that doctors do. And what we're hoping to do is to force doctors to start thinking in terms of those 200 things. So, but I think there has to be some bundling of what people do. We did that in healthcare, in hospital care a long time ago with diagnostic-related groups. It can be done. They're not, people within a diagnostic-related group are slightly variant, but it all averages out. And so we need more of that. In fact, in New York, the Medicaid director is working on a project to try and come up with items that you could call a bundle of services that look more like a product. Think about a car. A car is nothing but a bundle of parts, but you don't buy the door and the light. You buy a car with a whole bunch of parts in it. And that's what we have to do in healthcare, I think, is find out what is that bundle that represents a healthcare thing. We need shopping tools. It's amazing to me that we have a society where you can't tell what doctors your insurance company supports and what doctors are out of network. We need simple tools that you can just go online and say, that doctor today is in network. I mean, you know what happens. The brochure says they're in network. You go to that doctor, he says, oh, I used to be in that network. I'm not in that network anymore. Well, it should be updated every day. We do this, right? The airlines update their prices every day. Why can't we update the list every day? And there are companies that would be more than happy to do this if someone stepped up and was innovative enough to push it. Reference pricing, we talked about already. Quality information is another transparency point. You should know what the quality scores are of every hospital. Over half the hospitals in New York don't report to some of the basic quality reporting tools that are out there. We just don't do it. We should stop that. And this is what I like a lot. It's interesting. I'm on the National Council on Quality Assurance's committee that sets all the quality standards and the quality metrics. It's a very boring committee. But I'm told it's an honor to be on it. But anyway, and we meet and we decide how we're going to measure quality for this and that. And I keep saying to them, I said, if you go on Yelp, they don't have experts decide what is the quality. They let it come out inductively. And I'll tell you my personal story. I was trying to buy a Burr grinder for my coffee. It's a certain type of coffee grinder. And so I was looking at the Yelp, or I was looking at the Amazon things, and what were people talking about is that some of them are hard to clean and others are not hard to clean, and that's important. I never would have thought of that as a quality dimension. Never, but it turns out that's important if you want one of these coffee grinders. Well, in healthcare, we should be giving consumers a chance to say, what do they say is important about the healthcare experience? And we should measure that type of quality. We have very few tools. The ZocDoc is trying to put a tool for evaluating people, but they're nervous about it too. But we should have Yelp-like tools which are not outcome measures designed by the National Center for Quality Assurance, but are inductively determined by what people care about. So those are all types of things we can do for transparency, and again, we are interested in that. Patient-centered care models. I need to go faster, I think, so I'm going to run out of time, right? So patient-centered care models, this is one where I think we are making progress. I'm going to come back and talk about it, but I didn't press the button. But we need more of these things that are better managing people's care, creating a relationship between the provider and the patient. Again, my story here is, when my Honda needs to be serviced, I get calls all the time saying, your Honda needs to be serviced. Actually, CVS calls me when my prescription is due to get renewed relentlessly. In fact, I'd love to learn to turn that off. But I take this drug, warfarin, that means your blood is thin, and so I have to have a blood test every month to make sure it's right. I go to NYU Medical Center for my test. If I don't show up for 6 weeks, I don't get a phone call saying it's time to get your blood test done. Nobody ever calls me. If I haven't seen my cardiologist in a year, I don't get a call saying, you haven't been in to see me, you might be dying, please come in to see me. No call, so why don't we have those types of patient-centeredness out there? Okay, consumer experience and satisfaction. Again, this it's just all these things that are about basic consumer amenities that a lot of us in healthcare, myself included, never think about. I just sort of think they're trivial, but they're not. So we should attend to them. Okay, so those are some of the options out there. But again, I think we have to think big. So let me just use the last few minutes to say what's going on in New York, because that's always fun, so I think about. And there's a lot going on in New York that addresses these things. Okay, there are efforts, at least pieces of them, and there are these two huge programs, what we call DSRIP and SHIP. Do everybody know what those stand for? If you don't, you're a good person. But DSRIP is, let me get the initials right, hold on, is the Delivery System Reform Incentive Payment Program. Believe it or not, we got over $6 billion from the federal government to work on better integrating our healthcare system. So that's focused on integration, which would get at this care management issue and making things easier for it. I'll talk a little about that. We got another $100 million from the federal government to do the State Health Innovation Program, right? Innovation, not improvement. Innovation program, which focuses on improving primary care across our state, doing payment reform, and doing some population health on that. So those are the two major activities going on in our state. There's actually more than two. It's integration, primary care advancement, payment reform, a little bit of population health. There are two things that people think are a problem, and that we aren't doing much about market power, and we're not doing a great deal about disruptive innovation. So let me just sort of explain that. Then there are these other two things going on, which I probably want to get to, but is we're learning a lot better how to manage healthcare, I think, and we have a lot more big data that is very useful for better managing costs and productivity. So there are some nice things going on. So this is really what's shaping things. I say disrupt big data. We have federal politics that are keeping costs in the limelight. We don't want to spend more money. Governor Cuomo, if you said what does he care about in healthcare, it's keeping Medicaid costs down. I mean, that's sort of about what they care about for the most part. Affordability is a consumer concern, changes in cost control, and disrupt big data. So it's sort of covered that. This is why we do integration. Say, why are we spending $6 billion to integrate our healthcare system? That is and by integration we mean having providers develop relationships with one another so they can better manage a patient's care in an orderly way. And so it means you take a hospital, 50 physician practices, 5 or 6 mental health providers, some podiatrists, some, all these things, and you say you are now part of one organization. Maybe not in a legal way, but you agree to be partners, and then you figure out systems of how you can have your clinicians work better together to manage the total needs of patients. So that's the notion of integration. And the logic of it is that fragmentation leads to waste. Fragmentation leads to poorly coordinated care. That is, if you have all these different practitioners who aren't coordinated. Complex patients need a lot of different types of services. If you have severe diabetes with complications, you need to see more than one provider. You need care management. And importantly, integration is the first step towards payment reform. You have to have big enough organizations to accept risk and to be able to manage care. And so this is seen as one element to get to payment reform. So this DISRIP program, it's sort of all about meeting metrics, improving efficiency, and this and that. You get the $6 billion or your share of it if you do hit metrics and you do improve your outcomes. The biggest outcome that you get incented to achieve is to reduce unnecessary hospitalizations by 25%. There's a whole category of hospitalizations that people say they never should happen. If you did good primary care, you wouldn't have those, and those are the ones we want to reduce by 25%. The approach for doing DISRUPT is to get these organizations to integrate. They've basically funded 25 mega, organizations that are integrated across the state to be what they call performing provider systems. Okay, 2 of them in Syracuse, just one in Syracuse. Maybe too soon. So you can see why I worry about competition. If you have one of these that is dominating the market, you're not going to have a lot of competition. Funding, as I said, there was $6.4 billion in federal funds that can be used to transform your system, do all sorts of planning and change. You get that money if you perform well. And the idea in the long run is that these organizations will get integrated, will get to know each other. They'll be able to form what are called accountable care organizations and start taking risk-based payments. So that's really what they're hoping to do. The concerns with this, again, is that will this be anti-competitive? If there's only one here in Syracuse, I think there are 2 in Rochester. Is that enough competition to really keep prices in line and keep people doing it? And then the second concern is who is at the table shaping these? You'd think that you'd want to have primary care be the leaders of these, because if you do good primary care, you can do less, you can keep people from going to the hospital, and that's where the savings would happen. But in fact, I think it's 22 of these 25 PPSs are led by hospitals. One is led by a community health center, one by a physician group, and one by the Adirondack Health Institute, which is sort of a collaboration of hospitals and physician groups. So they're more dominated by hospitals, and you worry about, are they representative of the provider communities? So those are concerns. State Health Innovation Plan, this $100 million bucket, is about trying to think through how could we get better payment reform. And the state is committed, they say, to get 80% of reimbursements to be either capitated or value-based, or somehow to pay based on performance and not just fee-for-service payments. And then there's this advanced primary care emphasis, trying to get primary care practices to use more care management and more state-of-the-art, patient management approaches. The issue with value-based payments, which is key to the state health innovation plan, is saying, well, what does it mean? There are so many different definitions of value-based payments, and I won't go through all these, but we have to pick what we're interested in supporting. And then secondly, there's the how. I mean, who's going to come up with these reimbursement tools? Is it the government's going to dictate them? I don't think that General Electric or Syracuse University wants the government telling them how they have to pay for health care. So I think there's going to be a power struggle as to who's at that table to decide what these reimbursement approaches look like and who they apply to. The state is saying they'll apply to everybody, but I find that hard to believe. And then the skeptics, again, the concerns are, will they have teeth? Will they apply to a lot of what we do? How extensive will they be? And I actually moderated a panel of CEOs from around the country recently, and I asked them, how much do you think will end up being capitated or this sort of new type of reimbursement? And they all felt that 25% at most, and the rest would remain as fee-for-service. And it's not clear that that's going to be enough to really drastically change behavior or the way you think about that. Okay, and then I'm going to skip this one. I'm going to skip that one. So I'm going to go to say how I think we're doing, and sort of, I figure this is a university will have a scorecard or what do you call these? A report card, right? Sort of grades here. So I'm going to look at how I think we're doing on these various ways that you might address competition and consumer-centeredness. And A means we're making some progress and there's some hope it will work. B is, well, we're actively working on it, but I think I'm a little less hopeful that it will work. C is there's less activity, but there's some talk, so we might do it. And D is this is not an active topic at all. So let's see where we come out. On the affordability side, there really is a lot of effort to lower production costs of healthcare. I give that an A. So there's a lot of work going on to sort of look at every element of how a hospital or a healthcare provider delivers care. A lot of this big data is supporting that, and there's a lot of incentives to try and do that. So I think there is efforts there, and it might work. I think, for better or worse, we are incentivizing patients to shop for value, which is another key component of getting a competitive system. And we're doing that by having higher and higher deductibles. If you have to pay, you're going to all of a sudden be sensitive. And I'm actually working on this paper to say how many people never reach their deductible at different levels, and as they spend towards their deductible, what types of health care are they using? So what is, and the reason that's important is that you want to say, where would you focus your attention on transparency if you want to do that, right? And we want to do that. And so you want to focus on those providers that people who are below their deductible are using, because that's what they're going to have to pay their dollars for. So that's where you want to focus on transparency. Interestingly, as you might expect, people who don't reach their deductible tend to have many fewer hospitalizations. Much more of their care is in hospitals and in tests. So that's probably the most important things where we should have transparency is physician practices and different types of tests. And we think we do have more transparency there than in hospitals. So I think we're doing a good job. I worry about deductibles for other reasons, but we're doing there. Driving out low-value care. That is, saying, do we really need to do all these tests? Do we really need to do all these surgeries? And I'd say there's some activity there. Where there's some incentives and there's some work trying to drive that out. Not quite as hopeful about it. Efforts to keep people healthy. That's the cheapest way, or that's the best way of getting to be more affordable, is to get it so people don't get chronic diseases, that people don't have all these needs. And that's the population health side. And I should have talked about that more earlier, but that's one of the key possibilities. And there I'd say we get a C. There's not much going on, but people are talking about it. We're talking about it. Some of you are working on it, but it's not a central focus yet. And then the last two are the ones I think we're worst off at. I don't think we're worrying in this state about competitiveness. We seem to be pushing this integration agenda without competitiveness. In fact, the state government keeps fighting with the FTC when they voice concerns about competitiveness and say, oh, don't worry about it, we'll take care of it. But so that concerns me. And then the other one, we didn't really talk about it, but a lot of people feel that one of the reasons for high costs of healthcare is malpractice fears, defensive medicine, and if that's a problem, we're not working on it, not in this state. There just hasn't been much work on that. So those are the grades I give on affordability. And on consumer centeredness, I'd say encouraging care management, co-management, patient education. We've done a good job in this state of trying to do that, and I think there's some hope. We've funded these medical homes that are funding more care coordination. The whole integration attempt is focused on this, so that's front and center. Action to encourage more transparency. The state has actually done a fair amount on this. The Department of Financial Services has done a fair amount, and so I'm not sure it's working yet, but they care about it. Attention to amenities, I don't think we're doing much. Defining understandable products that can be priced. We haven't done much, but I think there's some hope that we will start. And then developing affordable options. I don't think we've done enough there either. So it's the one I would do it. At least there are no D's on this one, but there are a lot of C's. Okay, I'm going to stop there. In some ways, I think I worked in what our foundation might do, but I'll just summarize it quickly. Is we're going to start by worrying about transparency. Price transparency, information transparency. We have a big grant to Fair Health to build these it's going to be a website that'll allow you to figure out the price hospitals and providers charge for 200 different specific services. And then for about 50 bundles, things like hip replacements and knee replacements. And they have the ability to build that price by looking at which ICD-10 codes they use and stuff. And that's going to be made publicly available to every consumer in New York. So that's one thing we're doing. We're working with the Department of Financial Services to really say, is there any relationship between, all these factors like severity and teaching and stuff and price, to say what is driving price, and is it quality or is it something else? In some ways that builds on the earlier Syracuse project that looked at a variation in cost across sites, and I think some of them were the ones at Fair Health who pushed that. And then after that, I think we are looking at the whole issue of competitiveness and say, what do we need to know if we want to have a more competitive system? And we'll dabble with some of this disruptive innovation. Thinking of ways, are there some ways that we might seed some of these organizations or subsidize some of these organizations and get them up and going? So that's what we're up to. Thank you very much.
So Dr. Knickman has given us quite a bit to think about. I know we have maybe a minute or two for a couple of questions. So is there any questions for him? Yes, go ahead.
Jim, I guess I'm asking you to stand back and reflect a little now on 30 or 40 years you've been in this business. Because it struck me that sort of the first 2/3 or 3/4 of your presentation could have been given 30 years ago. The diagnosis,
Right.
and in principle, what are the remedies? What's newer is you talking more about what's actually being done now. So I'm curious. Do you have a lot of optimism that even though the diagnosis is the same, that the patient has prospect of getting a more efficient, higher quality treatment? That the patient, in this case, being the system?
Well, it's interesting. I think there is something different now than 20 or 30 years ago, and that's that I think the share that is in the face of consumers is larger now than it was, and I think it's going to grow. So the fact that it used to be we were spending all this money, but a lot of it was hidden. It was hidden in your employer contribution of premiums and various other ways. So I think it's sort of to me the potential thing that will cause more change now is the fact that it is hitting the paycheck of Americans in a big way, and especially working class and middle class. So that's one thing. Now, do I think anything will change? I do think things. I'm always an optimist, but I'm optimistic. First of all, on the cost side, I really do think that big data and really being able to understand the drivers of cost are going to get us to be better at that. So I think there's new tools that will allow us to get to be more efficient. And think about it, New York has kept hospital costs, really low for the last 4 years, and part of it's utilization, but a lot of it is taking dollars out of the system, and a lot of that is driven by better information about what's causing costs and stuff. So I think that's the good side on that. Now, as far as transparency and all those and consumer, getting the consumer more center, I don't know. There's just a lot more talk about it. There's a lot more people frustrated at the way the system is treating them. And I think the price transparency and the information transparency, again, there's better tools to get that out there. Like figuring out these bundles of care is pretty possible now. I'm not sure we would have had the metrics to do it 20 years ago. So that makes me optimistic that that'll happen. In some ways, I think some of the drive for improvement will come from the high deductibles, because now patients have skin in the game a lot more than they used to. And as I've hinted, I also have concerns that those high deductibles could lead people to use too little care and could be a problem. So I think we have to get it right. And I'm not sure that just what they call general deductibles, across-the-board deductibles, are the right way to go. I think we might see more, there's no deductible for these, there's a deductible for that, where it gets a bit more sophisticated on that side, too. But would I bet my life savings that it'll change? I'm not sure.
So, do I have to turn this on? So that's a really good sort of segue to my question. One of the interesting things to me about the healthcare world, and I don't much do work in it, is that you want to hold doctors and hospitals accountable for their performance in various ways, but the patients aren't held accountable. So if you think about this with really fairly few exceptions, you think about, participation in weight loss programs. There's certain things where they'll give you credit for good behavior. We don't actually hold the patients accountable. So if your brother gets the advice, so come back in 3 months, and he doesn't come back for 6 months, for, a year, and then things are worse, that's the doctor's bad. If I don't take my medicine, if I don't listen to the advice, or all of those things, there's no bad on me. There's no costs for me. So it's a funny way to think about this, where you're going to never hold the patient accountable for holding up their end of the bargain. It just sort of struck me as you went through this whole list. It's just nowhere on that. Is that? Do people talk about that? Am I? We're all going to walk out and say like, oh, that's the economist for you, or people thinking about this?
They do, and I think that there are some of that where you pay more these days if you smoke for insurance and things like that. So there's some of that going on. I think most people think that positive incentives are easier to deal with than negative incentives. To sort of try and incent positive behavior. But again, here's technology. That I heard a friend told me they just got one of these CPAP machines. That for people who have snoring problems or whatever it is, and they now have a chip in it that if you don't use it, what they do is they make you pay $50 a month or something for this thing. And if you use it, and it has a little thing that transmits back to the thing, if you use it, they reimburse you that $50. And if you don't get paid. So it's interesting how technology and sensing equipment can start to punish or reward you. I don't know if that's a positive or a negative one, but I guess they're looking at it as positive. They pay for it if you behave. But anyway, so I think there's possibilities of doing more of that. And I mean, that's a far-flung one, but I think it could be.
Maybe we'll take one more question.
Oh, lucky me. So, Jim, you talked a lot about introducing market or market-like forces, and I get the underlying theory. And you also alluded a lot to, you drew a lot of analogies to buying a car. Now, people often critique the market notion of the healthcare system by saying, well, there's ways in which it can't be a market. And let me just point out one is you'll never be in a situation, I would claim you'd never be in a situation where you've got to buy a car in the next day or two or you'll die. But, the heroic high-cost end-of-life interventions don't go to many people, but they represent a whole lot of the money. And I think that creates a situation where there's basically no holds barred on pricing. And I don't think you can overcome that. I wondered if you agree.
You might not at end of life, but I think there are ways around that, though. So for example, Philadelphia, maybe in Syracuse the same way, Philadelphia now has 2 health systems. That's it. It has Jefferson, it has Hub. Those are 2 health systems. And they have lots of integration and so on and so forth. You could, somebody just told me this idea, so that's why I bring in Philadelphia, is you could say to people, okay, there are 2 health systems, they're pretty good. You have to choose one. In other words, we're going to have a market where there's 2, and you have to choose one. You cannot go to both. Okay, so you can't have one that, all the Jefferson hospitals are in your network and all the Hub hospitals are. You have to choose one. Well, that would lead those 2 to have to start competing, and it would be more of a choice made up front, not in the emergency situation where you're about to die, but it's where you made a rational choice that I looked at it, and the price was better at Jefferson, so I picked Jefferson. Or I looked at it and I really liked the color of the rooms at Hupp, so I picked Hupp. But maybe that's what we need to do, is have sort of forced competition.
But people have to be willing to die to make their own choice.
Yes. Yes, but we're all going to die, and there are no differences in outcomes, by the way, between the Jefferson system and the Hupp system. But you would have that quality information, and you would know all that, and yeah, you might make the wrong choice, but I think that whole thing of it's a small percentage of healthcare choices that are made in when you're in the ambulance, and by the way, most ambulances are directed to take you to someplace you don't have much choice anyway. But anyways.
Okay, so we will have a reception immediately. We'll have a reception now. So Dr. Knickman will be here. I know there were several more questions, and maybe you could grab him afterward. We want to thank you again for such a wonderful lecture today.